Our next speaker is Dr. Sabeen Zia. Dr. Sabeen is a nuclear medicine physician at PSNM Hospital, Peshawar, and she has interest in theranostics. She has certificate in PET-CT and diagnostic CT. She also has a certificate in palliative care of medicine. Her topic of presentation is PRRT initial experience in the northern Pakistan. I welcome Dr. Sabeen Zia.
In the name of Allah, the Beneficent, the Merciful, I'm Sabeen Zia from PSNM Peshawar, and I'd give you a brief overview of our initial clinical experience with PRRT in gastroenteropancreatic neuroendocrine tumors. Before moving forward, I'd like to express my gratitude to the leadership and guidance of Chairman PAEC, Dr. Raja Ali Raza Anwar, Dr. Masood Iqbal, Member Sciences, Dr. Akifullah Khan, Director PSNM, who always takes the initiative and then inspires us to move forward, the efforts of Team IPD Winstick, our patients, and of course my team members. So the gastroenteropancreatic neuroendocrine tumors account for about 70% of the neuroendocrine tumors. They're typically slow-growing and rare tumors. Some of them secrete various bioactive amines and hormones that can create a clinical challenge. They're often diagnosed late when they have already become inoperable or metastasized, and sometimes after the development of carcinoid syndrome. On average, GEP-NETs take about 5 to 7 years to get diagnosed. Surgery is the initial preferred treatment. However, curative surgery is often difficult or not possible due to late diagnosis and extensive disease. Alternate conventional treatments include non-radioactive somatostatin analogs and cytotoxic chemotherapy. Another treatment option is PRRT using lutetium dotatate. So Irfan Saab has already shown you this slide, but I'll tell you a bit more about it. So the neuroendocrine tumors have a unique membrane chemistry that they have an overexpression of somatostatin receptors. The non-radioactive somatostatin analogs as well as dotatate take advantage of this overexpression. So you can see that the radionuclide, it's not working. Okay, anyways, the radionuclide is attached to a linker molecule, and this ultimately forms a PRRT complex. The PRRT complex is then internalized into the cell. It irradiates the nucleus, damages the DNA, and causes growth inhibition or cell death. So the radionuclide therapies are getting popular because of their expanding availability. Now suitable radioisotopes and specific ligands are available. We have a better understanding of disease pathophysiology. They have lesser complication, and they offer improved progression-free survival. In Pakistan, PAEC hospitals offering PRRT include Inmol Lahore, Noori Islamabad, PSNM Peshawar, and Kiran Karachi. We started PRRT with indigenously produced lutetium dotatate in September 2022. So far, we have enrolled 11 patients, and 7 out of these have completed standard 4 cycles of lutetium dotatate PRRT. Our patients are from various parts of Khyber Pakhtunkhwa, and 1 is from Azad Kashmir. More than 10 patients are still on the waiting list. One of the things that inspires us as doctors to keep improving is the gratitude and kind words of our patients when the prescribed treatment helps them get better. These are the words of one of my patients when she came for a 1-year follow-up after PRRT, and when I asked her about her health and her condition, she replied to me smilingly that "Juand uswan rakavi," this is a Pashto phrase which means that the life is now worthwhile. Let me show you her scans. So this 70-year-old lady with grade 1 neuroendocrine tumor presented with pain abdomen and a large multifocal inoperable tumor, and she was not responding well to any of the conventional treatments. I'm afraid the pointer, okay, it's working now. Here you can see that this is she received standard 4 cycles of PRRT with lutetium dotatate, and you can see that this is the post-therapy scan after first dose, and this is the post-therapy scan after 4th dose. At the time of 4th cycle, she was happy that her pain had improved, her diarrhea had improved, and she was able to sleep comfortably at night without pain. Her CECT and high-nictate scan 1 year after PRRT showed stable disease. Her baseline investigations were within normal limits, and she had only mild anemia, for which I gave her a bit of support. This is another patient, 60-year male patient, presented after the resection of an intestinal mass. He was on somatostatin analogs for control of flushing and diarrhea, and he had a solitary 35 millimeter mass in segment 7 of the liver. He also received standard 4 cycles of lutetium dotatate PRRT, and you can see that this is, I'm sorry, this is the post-therapy scan after 2nd dose, and this is the post-therapy scan after 4th dose. Here you can see that the tumor appears less intense, and it has a central area of necrosis. 6-month follow-up high-nictate scan and CECT showed no interval progression, and the patient reported better control of symptoms. So this is our team at IRNM. It includes nuclear physicians, physicists, radiochemists, a pharmacist, and nuclear medicine technologists. Lutetium-177 has a half-life of 6.7 days, and its beta has a range of about 2 millimeters. Lutetium dotatate binds to the overexpressed somatostatin receptors, and it has the highest affinity for subtype 2 receptors. Patient selection is a very important step. The tumor should be histologically proven neuroendocrine tumor with low Ki-67 index. All the lesions should be radiotracer avid on functional imaging, grade 1 or 2 neuroendocrine tumors on disease progression, and a subset of grade 3 neuroendocrine tumors can be considered for PRRT. Before PRRT, anemia or jaundice should be treated, and patients should be given enough time to recover from the effects of cytotoxic chemotherapy. Adequate bone marrow and renal reserves must be ensured, and the patients should be encouraged to maintain good hydration and frequently void during initial hours of the treatment. Baseline investigations include renal and liver function tests, serum electrolytes, blood glucose, and CBC levels. Short-acting somatostatin analogs were stopped for 24 to 48 hours before PRRT, and long-acting somatostatin analogs were stopped 30 days before PRRT. Patients were asked to continue their routine medication. Procedure was explained to the patients and their families. Written instructions were given, and written informed consent was taken. For pre-medication, 2 IV lines were maintained in arms, and an anti-emetic infusion was given. A commercially available amino acid infusion containing 15 grams of arginine and lysine each was started at least 1 hour before PRRT, and it was continued over the next 4 to 5 hours. The lutetium dotatate injection was diluted in 100 ml of normal saline, and it was administered over 20 minutes. The PRRT cannula was then flushed with about 15 to 20 ml of normal saline, and then it was removed, and pressure bandage was applied for 3 to 5 minutes. Pre- and post-therapy infusion set counts were recorded. Whole body and planar images were required 1 and 4 hours post-injection. SPECT CT images were required at 24 hours, and planar and SPECT images were required at day 7. This imaging protocol helped us to see the distribution and retention of radiopharmaceutical in all of the tumors, monitor the patient's condition for any early or delayed complications, as well as dosimetry. Dosimetry is a difficult task, and it often requires sophisticated and expensive equipment, but it can help establish the safety profile of PRRT, and also it can help in optimizing the delivery of PRRT with maximum dose to the tumors and minimum dose to the normal tissue, and it can also help evaluate the possibility of extended dose in disease progression. We perform dosimetry calculations for tumor or the target lesion, the kidneys, and bone marrow. I'll just skip this slide. Our follow-up includes baseline investigations 1 month after each PRRT cycle, and later every 2 months after the completion of PRRT, 4 cycles. Functional and morphological imaging is advised every 6 months, and oncology consultations are advised as per the oncology protocol. Patients were counseled regarding radiation protection, and they were kept in radiation isolation for about 4 to 5 hours after therapy. Following discharge, the patient's room as well as the team members in direct contact with the patient were surveyed for any radiopharmaceutical contamination. What we have learned is that patients should be facilitated for frequent voiding so that they are comfortable during the treatment. Any active complaints like pain or nausea should be timely addressed, and the PRRT team should be easily accessible to the patient via phone after discharge. In follow-up, we have observed improvement in patient symptoms and ECOG status. No disease progression was observed in any of the patients. Only mild or grade 1 renal impairment was observed in 2 patients, and adequate bone marrow reserves were observed in almost all of the patients. We also faced a couple of problems. First was finding an appropriate commercially available amino acid infusion due to unavailability of extemporaneous pharmacy in Peshawar. And secondly, there were delays in the supply of PRRT radiopharmaceutical, and we suggest that the capacity of suppliers should be sufficient enough to meet the demand of increasing number of patients. These are some of the references. So with this beautiful image from the historic Islamia College, Peshawar, I thank you all for your patient listening.